Can you, I'm muted right now. Can you grab my phone and watch email to make sure that if they email me any issues, it's right there? Are you in there? Okay. I wonder if we should ask someone about that. Okay, I'm going to try this now, everybody. And it sounds like the feedback is gone. And hopefully everybody can hear me. I know we're not quite ready to start. Scott says that's good. Yay. Okay. So Scott, I'll just kind of wait until we get everybody on. Yay. Thanks, Anthony. This is a new platform for me, so you'll probably see my business partner kind of popping in to help me. And, the next challenge will be sharing my screen, but I trust that we will figure all of that out and it will be okay. Just give folks another minute. Okay, it looks like we are on for 1:30. I don't think I can hear you, Scott.
And we'll go ahead and introduce the next session. I hope you all are doing well, have been enjoying your day and had a good lunch break for the last 45 minutes or so, but we are going to get back going again. So again, thank you for joining us at the Opera Fall Virtual Conference and our leadership track here. I've launched the CEU poll, so again, if you are seeking credits for this session, please check whatever credits you will be seeking for the session. So without further ado, we're very happy to have our next presenter, and please join me in welcoming Lara Palay from the Aldridge Palay consulting firm. Lara, it's all you. I'm going to turn my camera and mic off, and you can take it away.
Sounds great. Thank you, Scott. Hi, everybody. Okay, so I have my volume down and hopefully everybody can hear me. I had to turn that on to hear Scott. So hopefully everybody is hearing that okay. Maybe somebody could just kind of let me know. Looks like I'm getting some results that yes, people can hear me okay. All right, yay. Well, welcome everyone. My name is Lara and I really, thank you again, Anthony. I feel like Anthony, you're my letting me know if the volume is working guy. So thank you. You too, Scott. Okay. Well, welcome everyone. I'm very excited to have you here today. I know we have a very short time, so I'm not going to spend a lot of time on introductions, but I will say that I'm a clinical social worker. I've been practicing both in community mental health and in private practice, working with grief and loss and trauma for approximately 70 million years this year, I think. Now actually I've been doing it for about 30 years. And I'm very excited about this topic because usually we're talking about trauma and developmental disabilities. It's a lot of what my business partner and I consult in Ohio and around the country on. I've had the privilege of coming to Opera a number of times to lecture on some of those topics. And recently, I've really been getting interested in where trauma and empathy and burnout and compassion fatigue all come together. So for the past 12 years or so, or the past 12 to 18 months or so, I've been researching and reading and learning more about that, and that's become a part of what I've been talking to people about. So I'm very excited to get to bring some of those things together very briefly today, and we're going to jump right ahead into it. So I'm going to go ahead and try sharing my screen, and I hope very much that that will work. So we'll see. Okay, so I'm going to say yes. I'm going to allow them to share my screen. Okay, and I'm waiting for that to happen, and that seems not to be happening yet. So I'm going to have my business partner come and take a look at this. And we're going to try to pull these slides up. Oh, there we go. Okay, I think I've got that. And we'll start the slideshow, play from start. And hopefully you guys can see that and see me. So go ahead and let me know if for some reason you're not seeing that, but we're going to jump into this. I've chosen this photo, which is actually taken of my niece in the mountains, because it really captures for me what it's like for us as helping professionals sometimes, that we're walking through this terrain and it can be pretty rough and we can't always see where we're going. And so the question, what then must we do, I think is really what helpers are grappling with all the time. How are we going to deal with this enormous need that we are constantly confronted with professionally? And as I said, I got interested in this really about 18 months ago, but then of course COVID hit. And so now we are not only dealing with this overwhelming amount of need in our professional lives, but also in our personal lives. We may be struggling. Many of us are trying to be supportive to family members or friends. Many of us have people that we're caring for, children or other family members. And so suddenly this has become exponentially bigger in all of our lives. So really it couldn't be more timely. And I'm so excited to get to be a part of talking with you guys about this. A couple of notes. We don't have poll questions or handouts, so I'm getting the signal that something is going on. Can you get? I'm not sure if it means that you guys can't see the screen or you can't see me.
Can't see the.
Can't see the
screen. The share screen.
Okay, this has kicked me out, so I'm going to keep working on this. I don't know why it's not sharing, so we're going to pause here for just a second. Hang on. Okay, so here's me. It showed that it was showing the screen, not seeing the photo. People can't see the screen share. So let me try the screen share again. I think that's it. Nope. Okay, hang on. Share the screen. I don't know what this is. Entire screen. I don't know what's going on with that. I can try this again. Do I want me to go back? I'm going to hand this over to my partner for a second, so maybe we can figure this out. And while he's working on sharing the screen, I'll just keep going with this. So when I was really looking at all the factors that contribute to burnout and compassion fatigue and some of those issues, what I learned was that any kind of exposure to other people's trauma can potentially be, very, very stressful and damaging. So this is pretty cool. I don't know what this is, but we've got quite a display going there. And I think that that's a particular issue for this audience, for people working with developmental disabilities and dealing with, at times, people who've experienced trauma. And our field is learning more and more about how trauma is affecting the people that we work with. Many of the individuals that are at the agencies you serve or the county boards that you work at or what have you, we are learning more and more, I would say in the past 5 to 10 years, that I'm going to point that out there. I think we need to unclick that box. So we're becoming more and more aware how much trauma our folks experience, whether that's sexual abuse, sexual exploitation, trafficking, physical abuse, financial exploitation, all of those things. However, we still don't always know who that is or who's experiencing it and who isn't. So the problem with that is that when I go to my private practice and I work with someone and I know that they're coming in and they potentially are experiencing trauma, then I kind of can prepare myself for that. You know, it's sort of like I mentally put on some body armor and get ready for some of the things that I may be hearing. It's different if you don't know that's what you're dealing with. If someone is acting out a story or being very agitated or very shut down or whatever it is, and you don't necessarily know that that's what they're experiencing. So that's one problem. The other problem, I think, has to do with the nature of empathy itself. And if we can't get this sorted out, then we might just go ahead and skip the slides and I'll just talk to you guys and we can send the slides later. So this says he thinks I'm good if I go back to the PowerPoint. So let's try that and see if that works up there. Here's the other problem. If I were sitting in a room with you guys and I asked you all with a show of hands to say, what quality is it of yours that you feel is the most important for your work or that you value the most as a person? Probably a lot of you would say something like, well, I'm really good with people, or I'm a really good listener. And if we dug into that a little bit more, what you would tell me is I'm very empathetic. I have a lot of empathy for people. And so that's something that we tend to value very highly in ourselves. And I think that's great. I share the same thing. However, what we're learning about burnout and vicarious trauma, compassion fatigue, and we're going to talk about all of those terms in a minute, is that empathy is actually kind of the dynamic that can do harm. So if you can stick around for a bit, Kevin, that would be great. So we're going to really look at what is empathy, how does that work? And actually, we're going to find out that there are multiple kinds of empathy. So that as we talk about this, we're going to look at what kinds of empathy are beneficial, what kinds of empathy can actually be causing us difficulty in our work, and how we can be working with that as we all go through this crazy situation together. So we're not going to spend a lot of time on definitions, but I do want to talk a little bit about vicarious trauma, compassion fatigue, burnout, and what we're talking about with all of those things. They have a lot of overlap in the literature, and we don't need to really worry about that. But I do want to talk a little bit about starting with vicarious and secondary traumatic stress. So vicarious trauma seems to be when we are dealing with something immediately afterwards. So this is not trauma that we're experiencing as the victim of the trauma, but it might be something where we are immediately on the scene. So when I work with first responders and medical people, we talk about this a lot. In developmental disabilities, we tend to be in that role kind of occasionally, accidentally. So again, we don't always have preparation or training for it. We were working once with an agency that tragically lost one of their individuals due to a car accident. And some of the staff who worked at that group home were right there on the scene immediately after the accident happened. So that's an example of they weren't specifically affected by the trauma, but they were right there immediately afterwards. Or if you were someone who immediately has to go to the hospital or talk to the family or manage that situation as an administrator, that can be a kind of a breeding ground for this vicarious trauma. The next kind, and again, we don't have to spend a lot of time on these definitions. I want to jump ahead a little bit to secondary traumatic stress. And again, you'll see here that sometimes people also call this vicarious trauma, so people can use them kind of interchangeably. Secondary traumatic stress is probably more relevant to this audience today because secondary traumatic stress is when we may be in the presence of the disruption that the trauma caused maybe soon after, maybe months or years after, sometimes decades after. So, for example, therapists who work with trauma and hear traumatic stories all day long over and over again, even though these events may have happened very distantly from us, we eventually can become affected by that, and in some cases will show some of the same symptoms as PTSD. Some people will actually qualify for a diagnosis of PTSD. So we know that being around those traumatic events and being exposed to that trauma material can sometimes cause damage very similar to living through the trauma yourself. So that's just one little circle on that Venn diagram. And now I want to talk about go back a little bit. Some of the symptoms of vicarious trauma, and I'm just going to touch on these in a minute because we're going to then look at the symptoms of compassion fatigue and burnout. And really my point there is for you to see how much overlap there is. So difficulty managing emotions, and for me that means you're volatile, you're irritable, you're getting angry more quickly, you're crying more easily, feeling kind of the opposite, emotionally numb or shut down, a lot of fatigue, sleepiness, or difficulty falling asleep. And of course, you can have both things. Maybe sleep is disrupted and then you're fatigued during the day. Physical problems or complaints. A lot of people are, they kind of experience their emotional distress somatically. So you may not necessarily be aware of feeling sad or stressed or angry, but you do become aware that you've got these headaches or these stomach aches you can't quite explain or can't easily get rid of. These are just a few examples. Relationship problems, yes. People get drawn into work. They tend to lose their work-life balance. Avoiding intimacy or having increased conflicts in relationships, those are classic things that people experience. Kind of, I think of them as canaries in the coal mine, that when people start noticing those things, sometimes those are like early warning signs. And in this case, we're talking about vicarious trauma. But let's jump ahead and look at some of the symptoms for compassion fatigue, which is not a name that I like very much, and we'll talk about why in a moment. We know that compassion fatigue contributes to burnout, or some people say burnout contributes to compassion fatigue. Again, we're not going to worry so much about the definitions, but take a look at some of these symptoms that they list: exhaustion, insomnia, headaches, increased susceptibility to illness, somatization, which just means you feel your distress in your body rather than in your emotions, emotional exhaustion, distancing, depression. You notice already, and when I do this as part of a larger training about burnout and self-care, we usually go through these in a little more detail, but just this glimpse, you guys can see how much overlap there is. And there are a couple here that I really want to draw your attention to. The one second from the bottom, reduced ability to feel sympathy and empathy. I've learned over the course of my career to think about this differently than I might have early on. And I'll share a little bit about myself here. So if you had asked me early in my career if I was ever not being empathetic or sympathetic to people, I would have taken exception to that and been like, what are you talking about? Of course I'm empathetic. That's at the core of who I am. But I noticed that when I worked at Children's Services in the Sexual Abuse Investigation Unit for a time. I've worked a lot in crisis settings. And when I was a young social worker, I looked up a lot to the older social workers, and I kind of looked at them for how to behave. And there is this kind of person that would often be around who was sort of the hardened veteran, the jaded social worker who'd done it all and seen it all, and you can't surprise me, and nothing gets my goat anymore. And I really admired that and looked up to that and thought, wow, they're really seasoned, right? And I think sometimes that was true. But also what I know now is that what I was actually seeing was people who were distancing themselves increasingly from their job, who could not allow themselves to feel the emotions that their job was creating in them. And I don't say that critically or negatively. I think that when we lack any other tools, we do what we need to do to try to stop that when we just can't feel anymore. We can't tolerate it anymore. And what I learned to notice in myself when I was starting to get to that place, and I feel like this is a constant ongoing process, and so I'm always watching for this, and it can happen periodically, is when I am jumping ahead in the story. And this is something I also saw modeled for me as a young worker. Oh, you don't even need to finish. I know where this is going, right? And I thought, wow, they're so experienced. They've heard it all. Really, what I've learned is they were, I think, at least some of the time, jumping ahead to not have to hear the whole story, trying to distance themselves from the story. And I've noticed that I've done that. That's one of those red flags that I notice for myself, that when I kind of mentally jump ahead and finish the story, sometimes I'm embarrassed to say, I might even say that to someone. I try not to do that. But I know that I can do it in my head just as well, right? I'm jumping ahead. I'm guessing what they're going to say. I'm already jumping to my diagnosis or my plan or whatever it is. What I've learned about myself is that that is an indicator for me that I'm trying to avoid being present with the story. And that to me is a good indicator. It's like a check engine light, right? It's time to pause and pay attention to what's going on with me or what's going on in my life, that I'm trying to distance myself that way. And the last bullet on this, I think, is pretty much what I've already talked about, that what I thought of as being seasoned or being jaded or being a grizzled veteran on the job, and what I emulated and modeled from older staff people, more experienced staff people, I think what I was really seeing is cynicism. And cynicism to me is really just sort of scarred over pain. So again, I try very hard not to be critical with myself or with other staff people. When I see that cynicism, it's an indicator of pain, and it makes me want to pay more attention to what's going on. So again, we could spend all day together just talking about this, and some of this may resonate for you, some of it you may experience a little differently. But these, to me, are the things that we need to be very familiar and acquainted with as professional helpers, whether you are working with your client base directly, or you are supporting and supervising the people who do that, or you are a clinician or whatever it is. We are all, I think, obligated to learn and pay attention to these processes inside ourselves, because we're all human beings, right? And we all get to points where we feel like we're kind of at our limit for how much pain and distress we can be around. So I could go on and on with this. There's just one on this list that I wanted to point out for you guys: dread of working with certain clients or patients. Again, I will just speak for myself. We all know what it feels like when you look at your calendar for the week and you're like, oh, you've got that client or that meeting or that whatever, and you're like, oh. Again, I think that is pretty normal and pretty much just part of being in the world. I have learned about myself that when my distress is too high, then I'm not looking forward to this kind of turns into dread, to the point where, Sunday night, I'm already kind of worrying and ruminating about what my work week is going to be. At times when I'm experiencing a lot of distress, that becomes almost like panic. And I certainly experience some of that in my body as well. I will not share the details with you. Suffice it to say, my digestive system definitely responds to that level of stress. And so if you're feeling nauseated or panicky, or you can't fall asleep because of dread that you have about something coming up in your work week, that's a good example to me that your distress level has been maybe too high for too long. So again, we could go on and on, but I am going to jump ahead here and talk about, as I said, I hate the term compassion fatigue. I find it insulting, to be honest with you guys. I do not get tired of being compassionate and trying to live a compassionate life. But sometimes I do have stressfully high levels of distress. And the research that's being done into compassion fatigue and burnout suggests that we should really call it empathetic distress. We are empathetically linked to people who are in a lot of emotional pain, and we are taking that pain in to some extent ourselves. So really, empathy, that thing that we talked about that is often kind of at the center of how we see ourselves and what we value in ourselves professionally, also, there are kind of two sides to it. And the other side of empathy is actually the engine that can drive this this distress or this fatigue, or sometimes even getting us to the point where we show signs of traumatic stress. And I like this idea. This was originally, I think, from Tanya Singer, a researcher in Germany, that we should really be calling compassion fatigue empathetic distress fatigue, that we've just gotten too far on this continuum of empathetic distress. Well, in order to understand this, we need to break down what empathy actually is here. So there are really three kinds of empathy, and I did not know this until I started doing some of this reading and digging into this topic. So empathy, as we tend to think about it, is really emotional empathy, right? And that couple of other kinds of empathy first. So the first one is cognitive empathy. And cognitive empathy is the ability to recognize a feeling that someone is having, to label it or identify it correctly, but not feel it. Okay. And so an example would be if, I don't know, we'll pick Anthony. Anthony is a doctor in an emergency department at a hospital. There are patients coming in all the time in various levels of pain. Anthony needs to assess their level of pain to treat it or prescribe meds for it effectively. He's got to be able to very accurately identify the level of pain they're in and what is causing it. But he can't feel it himself. If he feels the physical pain of everyone who's coming in, his goose is cooked. He's done, right? So doctors, medical personnel, nurses often tend to be very good at cognitive empathy. They can identify it correctly. They don't feel it. Fun fact, another group of people who are also really good at cognitive empathy are sociopaths. Which makes sense, right? They are good at identifying how someone is feeling and manipulating that or mimicking it or whatever to get what they want. But they feel fine underneath. They don't feel any of that. So that's a fun little tidbit to share at night at dinner. Doctors, medical people, and sociopaths share that cognitive empathy. Then there's emotional empathy, which we're kind of familiar with. And then I want to jump ahead to compassionate empathy. It's kind of handy because there are two C empathies kind of bookending each other. So compassionate empathy recognizes and understands the feelings that another person is having, much like cognitive empathy. But it is combined with a wish for that person to be better or to feel better. We have a wish for their well-being. And there's a compassionate warmth that comes with that. Now, obviously, these are kind of mushy boundaries and people move back and forth. So this is not to say, for example, that medical personnel don't also have that compassionate empathy. It's really, I think, most useful in distinguishing compassionate empathy from emotional empathy. Emotional empathy, remember, we're feeling the feelings of the person to some degree, and when we're very pulled into their feelings, sometimes there's even a sense of kind of boundary loss, of kind of melding with them or kind of forgetting that you're not in their situation with them. Right? So when I talk with my students, when I teach at Ohio State, and I teach in the MSW program for largely trauma, grief and loss, clinical stuff like that, we sometimes talk about it like the person is in the water, you're in the boat, and then you jump in the water to try to help them, which, as we know, is usually not a great plan. So for me, when I'm feeling the feelings of the other person and I start feeling their distress, I start feeling panicky or shut down. We're going to talk about that more in a minute. Whatever that is, especially when I'm exposed to trauma material, they're going along the roller coaster of their often very, very painful, distressing story, and I'm going right along with them, right? Compassionate empathy, I recognize the feeling. I can accurately identify it. I recognize distance, right? So I have that deep gut awareness that I am me and not them. I am not experiencing what they're experiencing. Or another way to say that is I see them in the water and I know that I am still in the boat. And it's paired with a wish for them to be okay. And wherever possible, the ability to take an action to do that. And for those of you who are helpers, I know that your instinct is often to focus on the other person and not on yourself. So sometimes thinking about, wow, do I really want to pay attention to me? That can sort of rub us the wrong way. So this might help you. The research that's been done, and this is a very new field, so stay tuned. We're still learning lots and lots about this. But the research that's been done, there are two things that I want you guys to know that I think will be helpful. The first one is that these may seem like I'm just sort of like splitting hairs for this experience, but actually these are three different brain states. Our brains really can distinguish when we are in emotional empathy and we are feeling the feelings of the person, reacting as if we're in that situation that they're in or describing. And then compassionate empathy is a different part of the brain that's lit up. right? So on an fMRI, there's a different region that's activated. There's some overlap as well, but your brain recognizes as these are distinct states, so they really are different. The other thing that's important for you to know is that studies that were done, I think this was done with medical people, was that when they moved out of a state of emotional empathy and kind of merging with that person and moved into a state of compassionate empathy, they were aware of the feelings of the other, they had that warm wish to help, but they were also aware and conscious of their own separateness and their own okayness. They actually chose more effective interventions and were more instrumentally effective than when they were in a state of cognitive or emotional empathy. Ta-da! So you really will be not just helping to keep yourself okay and to insulate yourself against burnout, but also you are in some situations a more effective helper by doing this. Okay, so again, zooming through this. When we talk about the necessity for doing this in our field in particular, remember I said that anyone who's exposed to this stressful emotional material from other people really needs to be adept at noticing what's going on inside themselves and working with that to move into that state of compassionate empathy so that we're not going up and down with the person. It's especially true, I think, for us to really be intentional about cultivating that in developmental disabilities. Because as I said earlier, when I'm in my role as a trauma therapist and someone walks into my office and sits down for a session, I can sort of mentally and emotionally prepare myself for that. When you're on a shift or you're working with an individual or a staff person and they are dysregulated, which we'll talk about in a second, but essentially they're freaking out or they're shut down or they're living out their story by demonstrating their vulnerability and shutting down or by victimizing other people or whatever it is, you don't necessarily know that that's what you're being exposed to. So it's kind of like radiation, you know? If we're in the presence of radiation and we don't know it, then we can't feel it, we can't hear it, we can't see it, we can't taste it. We don't know that it's happening, but it's absolutely affecting us and impacting our bodies, right? So traumatic material, especially in the field of DD, either because the trauma is not known or reported, or sometimes because someone can't literally tell you, especially with our nonverbal folks, we may have no idea that that's kind of what we're actually interacting with, but we are. So when we talk about hyper and hypoarousal, again, a trauma training would be a training for a different day. Suffice it to say that our bodies, our brains, our nervous systems have these systems in place to deal with a threat. And to use an example of that, for those of you who aren't familiar with some of these terms, let's say that you're driving on the highway and a car is about to merge into your lane. They don't see you, and you have to jerk your car out of the way at the last second, barely avoiding a crash. Well, what happens to your body? Your heart's pounding, maybe you're hyperventilating a little bit, you might be sweaty and shaky. So what's happened is you've gone from your normal activation, how most of us go through our days, right? And we can handle a little bit of stress and we can, relax when we have a chance. You've gone into that hyperarousal state. So your blood pressure goes up, your heart rate speeds up, your body is dumping adrenaline and cortisol into your system. And that's that familiar fight or flight reaction, right? We're going to talk more about that in a second. So, sometimes for this visual, it's helpful to think about you're knocked out of that middle range, what we therapists will sometimes call a window of tolerance. And now you're in that emergency system of dealing with the threat, okay? Now, what some people will also automatically do, or sometimes if the threat is overwhelming or life-threatening or fight or flight isn't working or you're trapped, is to go into hypoarousal. And again, this is not like people with trauma or people with DD or anything like that. This is how all human beings are organized. We are all built to do this. So let's go into that just briefly. Most people are familiar with fight or flight in that red zone. Freeze is another one, and this is stillness at a high state of tension. So think about a rabbit that is in the path of an oncoming car and is frozen. You can tell just by looking that rabbit is at a high state of tension, right? That rabbit is like, and the second the car, swerves out of the way, that rabbit's going to take off. So it's stillness, but it's still very activated and ready to do something defensive, run away or fight or whatever at any second. So that's freeze. Now, fawn may be less familiar to you. In the trauma field, we used to call this tend and befriend. And this just means moving closer to the threat to neutralize it. So being appeasing, smiling, being submissive, being compliant, being friendly, that disability smile that sometimes we see with some of the folks we work with. They've learned that people will be nicer to them or less frightening or whatever it is if they seem friendly and happy. Sometimes some seductive behavior, maybe that same kind of, it's actually a threat response, right? This is how I'm trying to get myself safe. And so it's really fight, flight, freeze, fawn. And that's all at that top red zone band, okay, when we've been knocked out of our window of tolerance into that hyper arousal. And then collapsing and dissociating. Going back to that rabbit, imagine that the rabbit has been caught by a wolf. And the wolf has the rabbit in its jaws. And it struggles a little bit, but it can't get away. And it's about to be killed by the wolf. What does the rabbit do? It collapses. It goes limp. That's what prey animals are programmed to do because, if you're about to be eaten by a wolf, you don't need to stick around for that. So that's sort of a complete system shutdown. Dissociating is a more subtle version of that, but that's really taking two things that are usually connected and pulling them apart. So you may see that either professionally or even people where they're telling a story that is a story of them being very distressed. It's very painful. It's very upsetting. It's very scary. But they're telling it kind of robotically, like there's no emotion attached to it at all. That is where two things, like the feelings and the experiences, have been separated. Sometimes people will be so dissociated that they kind of check out. And you may have seen this. You can almost see it in someone's face when sometimes their eyes will travel to one corner or the other, and they'll just sort of take a little mental vacation. And if you're looking at them, if you know what to look for, they're kind of not there, right? So sometimes we will see collapse physically. Someone will literally collapse on the floor or go into that fetal position. Sometimes it's more subtle and they're kind of dissociating. And again, we all do, or at least have the capacity for all of these things. This is how our brains and nervous systems were built over millions of years. So for myself, when I am in let's say a session or a work setting or whatever, and I'm getting kind of hyper aroused, I'm getting panicky, I'm getting angry, I'm getting worried and freaked out, I can feel that in my body. I can notice that in my thoughts and my feelings. Dissociating, collapsing, I do that too. I don't hopefully collapse in a heap on the floor, but I do that same sort of shutdown when the stress becomes too much for me to tolerate. So again, zooming through because we have so much to talk about and not enough time. This is taken from the work of a wonderful trauma therapist named Deb Dana. Don't worry about the polyvagal stuff. That's a clinical training in trauma that I do that's bigger than what we're doing today. But I do like how she's organized this so that when we're in that, what some people call that engagement zone, I'm relaxed, I'm in that middle zone on the slide, I'm calm, I'm interested in other people, I can interact with people. Then thinking about what that feels like in my body, right? My muscles feel loose, my heart rate feels slow, my breathing feels easy, whatever, what emotions I'm having, what feelings I'm having, that's really important for me to get familiar with. And as helping professionals, we need to be very, very cognizant of when we are relaxed and calm and grounded in our bodies. Bessel van der Kolk describes grounded as, I know that my feet are on the floor and I know that my butt is in the chair. Pretty good, right? I know where I am. I'm in my body. It's okay. That hyper arousal, remember that fight, flight, freeze, fawn? I didn't really have space to put that all in there, but that I'm sort of, my body is dumping adrenaline and cortisol. I am ready for action to try to get myself safe or to deal with this threat. Okay. For me, I can feel my heart pounding. I'm very pale. Some people would say pasty. And so my cheeks will flush and I can feel it. It's like they're burning. Sometimes I'll notice my voice gets quivery. Sometimes I feel kind of nauseated. When I become aware of that in my body and I notice those feelings of panic or anger or whatever it is, I know that I am starting to get hyper aroused. And it may very well be that I am with someone who is hyper aroused and I'm kind of emotionally empathetic with them. I'm resonating with them and I'm going right up with them. Same thing works with the hypoarousal, that immobilized, shut down, collapse, dissociated state. For me, and again, I'll just share this, what I experience is sometimes I'll notice boredom or numbness, or I feel, or I'm yawning a lot, really feel cold and heavy. Now, those are just the signals that I've learned that let me know that I am now in that hypoarousal state. And if I'm in the presence of a client or a staff person or whomever, it may be that I'm emotionally kind of melding with them and I'm sort of going down with them. What this means for us as clinicians, as direct service professionals, and I just did this presentation this morning with some direct service professionals, which was wonderful. We should be in a practice all of our professional lives of becoming more and more aware of what it feels like when we are in these different places. So with this slide, many of us most of the time spend time, again, in that kind of that middle zone. We're empathetically attuned with somebody, but we're regulated. So we may be kind of feeling what they're feeling, but we are still regulated in ourselves. Or we're with someone who's also regulated. When we start going up into that empathetic distress, we become unregulated. So we are getting hyper or hypo-aroused, and we're getting sort of melded. We're kind of losing our own self-awareness. We're jumping into the water with them. And when we do that, we need to go all the way back down to the bottom of the pyramid into that compassionate stance. We're self-aware, we're self-regulated. I know that I'm back in the boat. I am not in the water. So for me, a really powerful example of this is when I'm working with grief and loss. If somebody is doing really intense grieving, let's say a parent who's grieving the loss of a child, that is profound emotional pain.